Welcome, everybody. My name is Michael Touchton, and I'm Associate Professor
Bem-vindos a todos, meu nome é Michael
of
Touchton.
Science at the University of Miami. I'm also Faculty Lead for Global Health at the University of Miami's Institute for Advanced Studies. I'd like to welcome an audience of more than 500 registrants on behalf of the University of Miami and the Institute for Advanced Study of the Americas. This webinar is being simultaneously translated into Spanish and Portuguese. Please select your preferred language in the meeting options feature at the lower right-hand portion of the Zoom screen.
En la parte baja del lado derecho de la pantalla podrá elegir el lenguaje en el que quiere escuchar el webinar.
We'll speak in English, but Dr. Lozano will speak in Spanish after a few opening remarks in English. You can remain in the same primary channel if you're comfortable listening to English or Spanish, or switch via the translation channel function at the bottom right of the Zoom screen. If you have any questions during the webinar, please submit them via the Q&A feature at the bottom of the screen as well. Finally, a recording of this event will be available tomorrow at the Institute for Advanced Study of the Americas website, which we will provide at the end of this session. It is my pleasure and honor to introduce our esteemed panelists. First, Dr. Julio Frenk is the 6th president of the University of Miami and has served since August of 2015. President Frenk also holds academic appointments as Professor of Public Health Sciences at the Leonard M. Miller School of Medicine, as well as several other appointments across the university. Prior to joining the University of Miami, Dr. Frenk served as the Dean of Harvard University's T.H. Chan School of Public Health. Before that, Dr. Frenk was Mexico's Minister of Health from 2000 to 2006. There he pursued an ambitious agenda to reform the nation's health system and introduce Seguro Popular, a program that expanded access to healthcare for more than 55 million previously uninsured citizens. Dr. Frenk was the founding Director General of the National Institute of Public Health in Mexico, and also served as Executive Director of Evidence and Information for Policy at the World Health Organization, among many other leadership positions. Dr. Rafael Lozano is Professor of Health Metric Sciences and the Director of Health Systems at the Institute for Health Metrics and Evaluation at the University of Washington. Prior to joining IHME, Dr. Lozano worked as Director of the Center of Health Systems Research at Mexico's National Institute of Public Health, and as Director General of Health Information at the Ministry of Health. Before this, Dr. Lozano served at the World Health Organization as well as Senior Epidemiologist for the Global Program on Evidence for Health Policy. Dr. Lozano is an award-winning scholar and public servant and received numerous recent awards, along with recognition as Researcher of Excellence in Medical and Health Sciences by Mexico's Commission of the National Institute of Health from Mexico's Health Ministry in 2017. Next, Dr. Felicia Knaul is Director of the Institute for Advanced Study of the Americas at the University of Miami and Professor at the Miller School of Medicine. Professor Knaul currently co-chairs the Lancet Commission on Gender-Based Violence and Maltreatment of Young People. She previously chaired the Commission on Palliative Care and Pain Relief and founded the Global Task Force on Cancer Care and Control. Finally, among many other academic accomplishments and social accomplishments as well, Dr. Knaul leads a research team at the Mexican Health Foundation and is the founding president of Mexico's Tómatelo a Pecho, a nonprofit organization that promotes breast cancer research, advocacy, and awareness throughout the Americas. Next, on our panel responding to questions and answers and discussion later in the seminar, Dr. Rifat Atun is Professor of Global Health Systems at Harvard University and the Faculty Chair for the Harvard Ministerial Leadership Program. Previously, he served as Professor of International Health Management and Head of the Health Management Group at Imperial College London. From 2008 to 2012, Professor Atun served as a member of the executive management team of the Global Fund to Fight AIDS, Tuberculosis, and Malaria, as the Director of the Strategy, Performance, and Evaluation Cluster. Dr. Atun has worked to design, implement, and evaluate health system reform initiatives for numerous governments around the world, as well as with the World Bank, the World Health Organization, and the UK Department for International Development. He's the author or co-author of more than 350 papers in leading journals, and is the joint lead for the innovation workstream at the National Center for Infection Prevention and Management at Imperial College. Finally, Dr. Patricia Garcia is professor at the School of Public Health at Cayetano Heredia University, UPCH, in Lima, Peru. She is Peru's former Minister of Health, former Dean of the School of Public Health at UPCH, and former Chief of the Peruvian National Institute of Health. Dr. Garcia has served as president of the Latin American Association Against STDs, as well as a member of the Pan American Health Organization Foundation's Technical Advisory Group. She is an affiliated professor at the University of Washington's Department of Global Health, as well as with the School of Public Health at Tulane University. Finally, Dr. Garcia was recently appointed member of the United States National Academy of Medicine, becoming the first Peruvian professional to hold such a distinction. We are honored to have all these panelists here with us, and in the next weeks or months, we will be honored to have Dr. Garcia with us again to present research from Peru at a future date. And with that, I will turn this over to President Julio Frenk. Thank you.
You are unmuted, Julio.
You might be muted. We can't hear you.
No, I'm now off mute, I hope.
Yes.
I hope you can hear me now.
We can.
Thank you, Mike, and good afternoon to everyone, and thank you all for joining us. Thanks to our speakers and panelists. The University of Miami is truly honored to host this very important conversation. Here at the university, we are leveraging our unique geographic advantage to forge research, education, academic exchange, innovation-driven partnerships throughout the Americas. And our Institute for Advanced Study of the Americas is the central piece of that strategy as it convenes and supports scholarship relevant to the region, continuing the great tradition of collaborating among students and scholars throughout the entire hemisphere. Working with partners in Mexico, Brazil, Colombia, Bolivia, Chile, and Argentina, the Institute has compiled new data in the Latin American Observatory for COVID-19. This observatory was launched in April of this year, and it tracks national and subnational public policy responses to the coronavirus pandemic. We're delighted today to share the platform with Dr. Rafael Lozano, who's just heard at the Institute for Health Metrics and Evaluation, the University of Washington. And I'm sure he's going to offer invaluable insights as we look at the state of the pandemic in the hemisphere. As you all know, Latin America has become a global hotspot for COVID-19 with more than 5 million confirmed cases. And although it concentrates only 8% of the world's population, the region has 43% of the average daily deaths worldwide. Beyond the suffering caused by the pandemic itself, long-standing disparities based on poverty, ethnicity, and sex and gender have been laid bare by the pandemic. In addition to that, health systems in the region face layers of exacerbated challenges, including shortages of medicines and staff. And to add to the complexity of the situation, due to severely reduced income, interruptions in public transportation, and fear, the people of the region may be reluctant to seek care. Professional and unpaid caregivers are at particular risk, with poor women suffering the most as they struggle to earn an income while caring for children, the elderly, and the sick. As we review projections on COVID-19 from the IHME and data from the observatory, the complexity of challenges in the region make one thing certain. Now is the time to shore up, not divest of, anti-poverty and universal healthcare programs in Latin America. Our hope is that by shedding light on what is happening across the region, we will not only provide important information, but become a catalyst for hemispheric action. I look forward to the presentations. I apologize that I'll be able to stay only for the first hour. I'll miss the last part of the meeting, but I'm very much looking forward to the presentations that follow. And I will now turn it over to the director of our Institute for Advanced Study of the Americas, Dr. Felicia Knaul, to continue the conversation. Felicia?
Julio, President Frenk, thank you very much for joining us today. We know that you are leading all of the work at the university and as a figure nationally and internationally on this issue, which is taking the lives and affecting the health of so many people. So we thank you tremendously for the time you're going to share with us today. I'll go ahead straight into the presentation. You should all be seeing the screen. And if I don't hear otherwise, I'll just proceed. First by saying I want to thank in particular Hector Ayala Ornelas for putting this presentation together with me and for working, obviously anchoring lots of the Mexico team and the data work. And to say that we are now working in collaboration with a broad network of institutions that is actually growing across the region. Our anchor institutions continue to be, of course, the University of Miami, SIDA in Mexico, and Tomatelo Pecho. But as you can see from the logos on the screen, we truly are now becoming a regional network and a growing regional network. And you'll see as we go through the data, I'll share just bits and pieces from some of our collaborating researchers and say that we are planning several webinars in the future that will give you the chance to be able to go in depth into their research in each of the countries that we're working in, including in this case, Bolivia, Colombia, and Chile. Overall, we're just going to go briefly through some of our results and some of the data that we can share on the global epidemiology of this disease. I'm going to leave most of that to one of the world's experts, which is Dr. Lozano. Briefly go through the methodology. I want to then give you a little bit more depth on what public policy and health policy looks like at the regional level and a little bit in the subnational, going into the 5 countries that we're studying through our observatory. And again, what's specific, unusual, unique about our observatory is that we have been able to go subnational in each of the countries that we're presenting to you, for which we're going to share our data. We review at the state and departmental level what policies are for COVID-19. This figure comes from the Financial Times. I think it's one of the best figures being able to show the flow of this disease. What you're seeing here is a 7-day moving average of daily deaths in the world through to the 31st of August. It shows you how this disease has flown from Europe through to the Americas, and now why Latin America, and particularly Brazil and Mexico, are the global hotspots and continue to be. This gives you an idea of what's going on, again, from the Financial Times, and that website, I think, is really, really well done and very interactive. Country by country, again, 7-day moving average of daily deaths. What we need to see here for Latin America is Brazil remaining very high at 867 deaths registered per day, although right now slightly below the United States. Mexico at over 500, but a flattening of those curves and that of Colombia as well. Peru slightly on the decline, Argentina going up, Chile on the decline, Ecuador relatively flat. So we're beginning to see some of these curves seeming to flatten out. Again, I'm sure Dr. Lozano will give us more on the most updated data of what that may look like in the future. We have now begun to map the accumulated deaths and cases in the world. And this is a map of the COVID world, the way it looks today. What you see compared to a basic world map on the left-hand side of your screen is an engorged, particularly United States, and then through Mexico and Latin America. If you compare that to the map of cases, you'll see a little more in terms of India and the growing number of cases that we're seeing there, but both maps look quite similar. And they're severely distorted compared to the regular map of the world that you would normally think of. They're distorted because we know that certain parts of the world are concentrating a lot of the deaths and a lot of the cases. Here, what you're seeing is rank and proportion of population for the 10 most populous countries in the world, then several countries in Latin America and the Americas and our region, Latin America. So while the Americas has 13% of the world's population, it's 55% of deaths accumulated to date, and Latin America, 8% of the population and about a third of deaths. The relationship between the rank order of deaths and population is, I think, especially interesting. China, infamous for this disease, the most populous country of the world, yet ranking 28. India, second most populous, ranking third. The United States, third most populous, ranking first. And you'll see as they go down. Brazil, the sixth, and number 2 in terms of accumulated deaths. Mexico, number 10, and number 4 in accumulated deaths. And then we have a group in our region, very worrisome, that are not the most populous countries in the world, but have accumulated a large number of deaths in terms of the rank order compared to their population. So that's why we're calling this region a hotspot. And that's why we believe that we need to think at a very subnational and even municipality level, of what the countries need to do. So this observatory data that we've presented before in this series has, what it tries to do is collect, and has done, is collect data in an organized daily fashion across the region, and again at the subnational level, focusing on public health policies. Without going into tremendous depths, we've presented this before, while we're now collecting a number of additional indicators and a number of additional variables. Our overall index of the adoption of public policies for COVID containment is based on these 9 variables and builds off of the Oxford government's response tracker, but does 2 things. Again, at the subnational or state level, we're weighting and adding up across countries, and then we reweight according to the date in which each state or each department, each entity at the subnational level has adopted a particular policy, with the idea that adopting late is worse than adopting early. Here are some of our newer results from across the region. Again, we're presenting primarily the countries that we've been working on in depth: Bolivia, Colombia, Chile, Mexico, and Brazil. I'm sad to say that when we think about the index of adoption of containment policies, Brazil and Mexico, and these are data up to the 23rd of August, are way below the rest of Latin America. Nicaragua, we've left there in a dark brown dotted line because we know that almost nothing is going on in Nicaragua in terms of containment policy. So that's sort of the lowest common denominator in this index. And the other countries rank up. The gray lines in the back are the Oxford indicator, which does more at the national level and the subnational level. You see that Bolivia has been opening, and Chile, Colombia are basically steady up to the 23rd, but as you'll see in a minute, they're planning on opening up going into the future. We've now also been measuring not mask use, but rather whether or not states and countries are making it mandatory to use masks. And here you have our data for Colombia, Bolivia, Chile, Brazil, and Mexico. Again, and unfortunately, Brazil and Mexico lagging. All countries in the region, however, other than Nicaragua, have, as of the middle of April, begun some kind of policy, typically not mandatory and with no enforcement around the use of masks. Colombia started before anyone else when they were seeing their first cases. And one thing we want to emphasize in this presentation and in this webinar and going forward is how important it is that all countries try to increase the amount of information that's available to their populations on the correct use of masks. It isn't enough to say that you simply put the mask on, but you have to say when, how it fits, and how you're touching the outside, for example. So that kind of information, intensifying that information on the public health side, we feel is very important. We're also tracking mobility across the region as the opening up is happening. These mobility data from Google, you can do a rank total here. This is an average over the entire period. And again, we see that Mexico and Brazil have, over the period, done less to be able to contain their populations, and their populations have moved around more than any country in the region other than Nicaragua, again, with no containment policy. In terms of the tests per thousand population, which is another piece that we are monitoring, although I know Dr. Lozano will go into more on this. These data come from Our World in Data. Again, it's a moving average over 7 days from March through to August. Uses the United States and the UK reference. Chile, definitely on the upswing. Colombia beginning to be on the upswing. We have relatively poor data for Brazil, but basically Mexico, Ecuador, Brazil, Argentina, Bolivia, Peru, and Costa Rica really concentrate in the bottom of that figure as having very low testing in terms of tests per thousand population. Now, when we look at the positivity index, which causes, I think, some degree of confusion, and appropriately so, the positivity index can be high either because countries are not testing, or it can be high because there's a lot of disease. We believe this is showing something about testing and being able to test both symptomatic and asymptomatic populations, which is absolutely essential to be able to manage this disease in terms of brotes or outbreaks, rather than with the general lockdown. So the recommended level for this indicator, according to WHO, is about 10%. Here's what we know for the UK, Spain, and the US. Here's what we know for Chile, again with data from our colleagues, that huge upswing, and then a large increase in testing. And here's what's happening for other countries in the region for which we have, I think, solid data. Mexico, Argentina, Bolivia, Colombia doing better than the rest. But definitely those 3 countries at the top, and particularly Mexico, are simply not testing enough, which is why the positivity rates are 6 times what WHO is recommending for countries. And again, we believe that it's impossible to be able to have a reasonable strategy of containment via outbreaks and be able, therefore, to open up and allow the population to begin to go back to work and move around without having sufficient testing. Now, I want to just show you some of the data at the subnational level, and quickly, we have significantly more data available, but to give you a bit of a panorama at the subnational level. So this is just the piece of data on whether or not Mexico, state by state, because there is really no national policy on this, is mandating or recommending the use of masks. And we now see the states clumping. Very sadly, Chiapas, one of the poorest states in the country, very low on our index, and with a huge spread of about 53 points. Nuevo León, Mexico City, Jalisco, and a group are up at the top. Nayarit has really changed its policy significantly, and they're at the national level or above. And then we have this block of states that are doing better than Chiapas, but are still way below the national average. So this leaves huge room for improvement in terms of public policy around the use of face masks. These data are from our colleague, Dr. Sanchez Talanquer, who's actually, thank you very much, Marina, doing translation for us in the background into Spanish. But this is his slide, these are his data, but I'm showing you an integral member of our team. And we have been very surprised to see data like this on the differences in death rates by institution in Mexico, with something seriously worrisome going on, particularly in the Social Security, as well as overall in the public sector compared to private sector hospitals. And he has a publication on this in Nexus. Again, Dr. Sanchez Talanquer's data. What we're seeing here, we're beginning to look at the municipality level, which is much more granular. On the left-hand side of your screen, you're seeing municipalities that are less poor or marginalized, given the marginación index that we have in Mexico. And sadly, what we're seeing is that there's much more testing per capita in wealthier municipalities than in poorer municipalities. It's a huge equity concern for the country. Turning to Brazil, and here I'm sharing data that was put together largely by Professor Mike Touchton, who is our moderator for today, who is the lead for the work on Brazil and also co-directing the project with us. And what you're seeing there is a political pandemic that's driven by party politics, left, center, and right. And what we've learned from Dr. Touchton's work is not only that the president, as many of us know, has truly been an obstacle to appropriate public policy, the opening has also been anything other than prudent, with very low testing and very little contact tracing. So again, we're seeing a political pandemic here. The governors and states on the left that are against Bolsonaro, many of which are very poor, are responding much more rapidly and in a much clearer way in terms of their public health policy to containing this pandemic. Turning to Bolivia, again, data of one of our associated researchers, Dr. Hummel and her team. Dr. Hummel Cala is from the University of Miami. And what she says about Bolivia is that we do see a country that's had a national policy frame from which to work. Yet we're seeing a pandemic that's out of control. There were rigorous public policies early on and they were national, but they didn't seem to be enough to contain the pandemic. That while the country decided early in June, as we saw in the comparative data from our index, to begin to relax and allow the population to move around more, the pandemic simply got worse throughout the country. And today, we have 115,000 or more cases that are confirmed and a mortality rate of 8% in a country whose health system is being devastated, very sadly. Colombia, and this is our colleague, Dr. Otero from the University of Rosario, and a large team of researchers from Colombia, based in Colombia, and also some of our students at the University of Miami, who have been collecting data at the departmental and also municipal level throughout Colombia. And they share with us that this is a containment strategy that's been national, it's come from the national government, so there is a national strategy, but there is tremendous variation at the subnational level in the incidence of the virus and in the capacity to test and to trace. The positivity rate is very different across departments, as you can see in our provinces, as you can see in the graph. And she signals Vichada with 4% versus Cajetá with 46%. As of the 1st of September, i.e. yesterday, the country is opening up, yet without taking into account this systematic variation at the subnational level that's so important to have an effective strategy. So she and her team conclude that Colombia wants to transition to a policy that's based on identifying rapidly cases and to work on managing outbreaks, but it doesn't have the how. It's not going to be able to do that unless they're thinking much more carefully at the subnational level. Finally, Chile, and this is the result of the intense work of two Chilean researchers, Drs. Perez and Unduraga. We're very grateful, and we can say that Chile, we believe, is today an example to follow for the rest of the region. This despite having a very serious epidemic going on in the country. So Chile put at play a rapid and centralized national strategy. They implemented a strategy, and this has been going since the 1st of June, that involved local or municipal shutdowns, and those that have taken an entire city have been the most effective. But the ability to, and they've rapidly expanded the ability to do testing, as well as taken over in a centralized way the management of access to hospital beds and to resources that are necessary for the health system to be able to respond. So what we're seeing in Chile, that we're not seeing in any other country that we're studying at this point, although we believe that Uruguay is in a similar situation and possibly Costa Rica, is that this is a country that is able to have a policy that is based on contact tracing, testing, and focusing its efforts on outbreaks. This is huge because focusing an effort on outbreaks means that the population can begin to safely get back to work and to manage the other part of this pandemic, which is the pandemic of poverty that's being generated throughout the region. I invite you to look at these data in greater detail, to play with them at our website that we have thanks to the University of Miami School of Communication. And thank you very much for your time. And I'll turn it over now to Dr. Lozano.
Thank you very much, Dr. Felicia Knaul, for your presentation. Let me share screen. I hope you can see it. Let me put in the proper way. Okay. So, first of all, let me thank sincerely the president of the Miami University and old friend. It's my privilege, Dr. Julio Frenk. Thank you very much for inviting me. Thank you, Dr. Felicia Knaul, to invite me to this seminar. And I'm very pleased to have these panelists, very good friends and very good researchers, Dr. Garcia and Dr. Rifat. I asked Dr. Felicia Knaul asked me, how do you want to present? And I decided to do the inverse. I mean, presenting my slides in English and speaking in Spanish, because I asked, is there a translation of Spanglish? Since no one speaks Spanglish, only me, I prefer to switch into Spanish. Thank you very much. La presentación que les voy a hacer tiene que ver con el trabajo de mucha gente del Instituto para la Métrica y Evaluación de la Salud, que fundamentalmente nuestro interés son las proyecciones en este momento de la mortalidad de los casos y las estamos presentando al 1 de diciembre de este año. Si yo tuviera en este momento que terminar la presentación, yo les diría, los resultados es que a final de año, la primera causa de muerte en la región, desde Alaska hasta la Patagonia, es COVID-19. Les estoy presentando el resumen de una semana, la semana del 1 de diciembre, pero está lejos de que la segunda o tercera causa alcancen y estamos asumiendo que va a ser uniforme la mortalidad durante el año. Y la razón es precisamente el incremento exponencial de la mortalidad en los países de la región y particularmente los más grandes. Estamos estimando 826,327 defunciones por COVID-19 para el 1 de diciembre, con dos escenarios. Un escenario que le llamamos el peor, 889,000, que podría simularse como una situación de inmunidad colectiva de grupo o técnicamente llamada inmunidad de rebaño. Eso nos llevaría, y el tener un escenario optimista con resultados relacionados con la introducción de uso de cubrebocas al 95% de la población y también cerrando la economía cuando es necesario, nos llevaría a una mortalidad de 721,000. O sea, estamos de alguna manera presentando que se salvarían más de 100,000 vidas de hacer una política adecuada. En la parte inferior les presento lo que sería la mortalidad diaria y ustedes pueden notar un incremento a partir del mes de noviembre que está relacionado con nuestros supuestos de estacionalidad en la región. Como me dieron más tiempo, les voy a presentar 6 puntos que son los que están en la diapositiva. Déjenme empezar por el contexto. Nosotros empezamos este trabajo en febrero, cuando el hospital de la Universidad de Washington nos pidió que le ayudáramos a prever cuándo iba a ser el punto máximo de la epidemia para estar preparados con el número de camas. A partir de eso, nosotros hemos ya realizado 38 rondas y presentaciones de resultados. Todos aparecen en la liga que ahí les muestro y hemos actualizado en 3 ocasiones la estrategia de modelación. La cobertura geográfica empezó en un estado, posteriormente en todo el país en el mes de marzo, posteriormente en los países europeos, en los países de América Latina, algunos países de Asia y muy pronto, quizás esta semana, haremos la presentación de las estimaciones mundiales donde incluimos resultados sobre India, sobre China y los países africanos. Nosotros tomamos información de la Universidad Johns Hopkins, de la base de datos de Our World in Data, Y IHME extrae información alrededor de 50 países directamente de las páginas web de estos países. Todavía sigue siendo una base de datos chica en comparación con lo que tenemos del GBD, pero crece todos los días. Y están trabajando en este grupo 21 personas de tiempo completo y 58 personas como un servidor de tiempo parcial, pero por eso les digo, este es un trabajo en donde yo simplemente estoy transmitiendo la experiencia de este grupo y de una grande cantidad de colaboradores que agradeceré al final. La información que nosotros utilizamos de manera directa tiene que ver con las muertes que suceden todos los días, con las admisiones que se dan en los hospitales. A veces tenemos oportunidad de utilizar censos hospitalarios, con los reportes que se hacen de casos. Regularmente son casos que son comprobados, que son positivos ante las pruebas diagnósticas que hacen los gobiernos. Un resultado muy rápido, esta es la tendencia hasta el 20 de agosto. Ustedes pueden observar la variación que se da a finales del periodo, pero si suavizáramos la curva del lado izquierdo, la de los casos, veríamos que hay, pues de alguna manera está estable hasta el momento. Y la mortalidad insinúa una disminución cuando hacemos la suavización de esa curva. Cada uno de los puntos representa los datos que estamos registrando. Tenemos que corregir muchos sesgos. El primero es que Perú, Ecuador, tenemos que hacer una evaluación diaria de todas las causas de mortalidad utilizando el método de exceso de mortalidad. Aprovecho para agradecer al gobierno peruano y particularmente a mi colega Patricia Garcia y a César Cárcamo, que han sido fundamentales en compartir los datos, y gracias a eso podemos hacer estas estimaciones y mejorar el subregistro. También hemos optado por utilizar las encuestas de prevalencia que miden anticuerpos, lo cual nos ayuda a mejorar la evaluación de qué tan completo es el registro de muertes y detección de casos. Y quiero hacer énfasis sobre todo en este último punto porque hemos cambiado la metodología, incluyendo en esta última ronda lo que sería la relación entre infección y muerte, pero en lugar de utilizar los datos positivos, los datos de casos positivos presentados por los reportes de gobierno, estamos utilizando los datos por edad que presentan las encuestas de prevalencia. Son alrededor de 1,149 puntos, y para nuestra sorpresa, pues efectivamente hay un gran efecto que les voy a mostrar a continuación en algunas regiones del mundo y no en otras. Esta gráfica son los puntos que se observan. Ustedes pueden ver, es una gráfica donde está la mortalidad de toda la población por grupos de edad. La edad está en el eje de las X, la tasa estaría en el eje de las Y, y lo que podemos observar es que el riesgo de morir en un niño menor de 1 año es el mismo que de un joven de 25 años. Y esto nosotros no lo estábamos captando en nuestro modelo anterior. En nuestro modelo anterior lo que hacíamos era lo que está en la línea naranja, en donde de alguna manera sobreestimábamos la mortalidad de los jóvenes y subestimábamos los casos de los jóvenes. Y esto le da un giro total a la epidemia, particularmente en algunos países donde la población de menores de 25 años es importante, y sobre todo los análisis que hicimos en la India nos ayudaron mucho a esta nueva incorporación y que de alguna manera está afectando nuestros resultados. Otros datos que incorporamos en nuestros modelos, nuestro modelo se los voy a presentar, es el típico modelo estadístico de epidemias, pero hacemos un híbrido para ayudarnos en términos de las estimaciones, sobre todo relacionadas con la proyección a mediano plazo. Algunos resultados, ya presentados algunos por la doctora Felicia Knaul. Lo interesante es ver el mapa con un gradiente y vemos cómo Estados Unidos y Canadá se acercan más a lo que sucedía antes de la epidemia. Uruguay y Nicaragua. Nicaragua es un país que no podemos tener mucha certeza en los datos, pero Uruguay sí, vean cómo está en una fase diferente. Incluso República Dominicana se alcanza a notar ahí ligeramente, pero el resto están todavía bastante guardados de alguna manera en América del Sur, en Chile sobre todo, en Colombia y en Perú. Este asunto de las pruebas es toda una polémica y finalmente les puedo decir que la diferencia es brutal entre lo que sucede en la región, lo que sucede en el mundo, lo que sucede dentro de los países. Para los que vivimos o pertenecemos al país de la línea verde de la gráfica del lado derecho, pues es vergonzoso que no podamos decir que estamos viendo la epidemia como la ven otros países. El caso de Perú también yo lo tomaría con cuidado porque están sumando pruebas rápidas a las pruebas de PCR. Esta es la estadística que estamos haciendo con Facebook. Premise es la compañía que nos presenta los resultados. Y estamos viendo algo que a mis colegas les ha costado trabajo aceptar, como que en Latinoamérica está mejor que en Estados Unidos o que Canadá. Pues sí, es cosa de darse la vuelta. El doctor Frenk, la doctora Knaul me dirán cómo se comportan en los bares y en los restaurantes, no porque ellos estén ahí, sino porque es como si la gente no usa la mascarilla, que en Seattle tampoco con la frecuencia como la usan en otros lugares. Sin embargo, habría que decir que definitivamente aquí estamos midiendo el uso, no la calidad del uso y qué tan bueno es el tapabocas, pero es claro que es alta la cantidad que hay en la región. El modelo de transmisión es esto, no les pienso explicar las fórmulas, simplemente decirles que lo que estimamos, como todos los cálculos, es el número de susceptibles, la S, el número de expuestos. La primera I son los infectados con síntomas, la segunda I es los infectados sin síntomas o asintomáticos, y la R, que tiene dos salidas, los que recuperaron y los que fallecieron. Y el resultado, les muestro aquí algo que es muy característico. Si estás por arriba de 1, la R efectiva quiere decir que un caso es capaz de infectar a más de un caso. Si estás por abajo de 1, quiere decir que un caso infecta menos personas. Y se ve claramente en esta gráfica que la R que estamos calculando para el estado de Florida, justamente en estos momentos, pues está generando una tasa de infección alta, y eso genera mucho más casos que después empieza a moderarse a lo largo del tiempo. Si lo vemos en la perspectiva de la región, podemos ver que en el caso de Paraguay es donde está más alta, el caso de Surinam está más alta ¿cómo se dice?, la tasa de infección efectiva, en el caso de Uruguay y Argentina también, y en el resto de la región un poco menos que estos países, lo cual son buenas noticias. Si lo vemos al interior de los países, en el caso de México podemos observar que 3 estados todavía están rezagados. El estado de Morelos, la bolita que está en medio, arriba del grande, que es Guerrero, y otra bolita que está arriba, que es Aguascalientes, y Brasil, solamente un estado rezagado. Para nosotros decir que nuestro modelo sirve, pues tenemos que validarlo. Les voy a presentar muy rápido la validación que hicimos. Hay mucha gente que trabaja modelos. Aquí estamos seleccionando algunos. Un modelo, el típico, el de Delphi, otro modelo bastante completo, el que se hace en Los Álamos, el que se hace en el MIT con este investigador, el que se hace en el Imperial College y lo que estamos haciendo nosotros. Les pude haber traído una gráfica compleja, les traje nada más Brasil, utilizando 2 componentes, la mediana del error y la mediana absoluta del error. Y podemos observar en los colores que lo que se pueden usar, porque no varían mucho algunos modelos, pero no se pueden recomendar otros, como es el del Imperial College, que se ve claramente que se sale de lo que estamos utilizando los demás. Ningún modelo está escrito en piedra, los modelos se modifican a lo largo del tiempo. Aquí estamos proyectando 6 semanas, ya tenemos hasta 10 semanas, y el comportamiento es muy similar y lo tenemos analizado por región y por país, como ustedes lo ven en la gráfica. Los resultados de predicción, fíjense que nosotros pedimos recomendaciones en diferentes lugares y algunos decisores nos dijeron, no te puedes quedar solamente con una proyección, si nos ayudas con escenarios es mucho más recomendable. Nosotros recomendamos mucho pensar en el peor escenario. El peor escenario es prácticamente regresar al pasado. Y esto mucho tiene que ver con la relajación que algunos países han hecho en términos del mandato, pero por otro lado también tiene que ver con esta estrategia un poco oculta que se puede decir de la inmunidad colectiva o inmunidad de grupo. Tenemos otro que ya cada vez dudamos más, y es una de las preguntas que les hago al final, que es la reimposición de los mandatos cuando subimos una tasa de mortalidad. Prácticamente nadie quiere reimponer los mandatos. Y yo creo que aquí el problema es cómo podemos ser más ágiles en el regreso a ciertos mandatos y no a la totalidad. Y por último, sumar el uso de cubrebocas a un 95% de la población. Yo ya les había presentado este resultado y piensen en la línea de color rosa o clara, no la verde, sino la de arriba, como el costo que tiene para la sociedad el relajarse y por otro lado, el relajar el mandato y por otro lado decir que, bueno, vamos a llegar a tener una inmunidad de grupo que nos va a proteger mientras llega la vacuna. Estos son los escenarios que tenemos que discutir, coberturas de vacunación y bueno, no sabemos cuál es la inmunidad de grupo. En algunas enfermedades es el 50%, aquí se ha dicho que puede ser hasta el 80% y la verdad es costosísimo para una sociedad en el número de vidas que se estarían perdiendo. Otra manera de ver la proyección es diciéndoles, bueno, el 1 de diciembre, ¿cuántas muertes por día, por millón de habitantes estamos calculando? Y en este sentido tiene que ver también, si ponemos un escenario de 8 muertes por millón, pues todos los que tengan más de 8 muertes por millón deberían de estar muy preocupados por el incremento de la mortalidad para ese tiempo. Y es claro que pues está en Centroamérica, está en México, está en Haití, donde es más preocupante el incremento, pero también en los Estados Unidos. Y si algo les llama, no sé si les llama la atención que el sur está con menos mortalidad, y aquí es donde la estacionalidad juega un papel importante. Regresando a la discusión, ¿cuántas personas están infectadas? Nuestro modelo decía, no te voy a decir cuántos casos positivos hay, te voy a decir cuántas personas están infectadas, la prevalencia de la infección en la población, y tenemos sociedades con un 44% que se ve ahí, el caso de Ecuador, más del 44% el caso de Ecuador, sociedades con más del 30%, México, Perú, en Centroamérica, Panamá, y sociedades con países con poca inmunidad como Uruguay, con poca prevalencia de casos como Uruguay o Canadá. Esto trae en consecuencia también la discusión de qué tanto se está dispersando la infección en la comunidad. Voy a regresar al asunto de las principales causas y voy a tomar el ejemplo de Brasil. Esto es ahora, al día de hoy, la semana del 20 de agosto, la primera causa de muerte en Brasil es el COVID-19. Y si proyectamos esto a diciembre, vemos que el COVID baja al segundo lugar. Y la pregunta es ¿por qué? Y justamente es por el efecto que está generando la estacionalidad de la neumonía y de las infecciones respiratorias que están por venir en el resto del año para Brasil. Si les presento el caso de México, vemos un escenario completamente diferente del hemisferio norte. 3,000 muertes en el momento, en el promedio semanal, en el primer lugar. En México no hay duda de que va a ser la primera causa de muerte al finalizar el 2020. 6,000 muertes en promedio, lejos de lo que sería la cardiopatía isquémica. Y por supuesto ustedes ven la tendencia de justamente la estacionalidad de lo que se avecina. Entonces el argumento aquí también tendría que ver, oye, y alcanzarán las camas de hospital para ese momento. Es una discusión que tenemos que traer a colación en su momento. ¿Cuáles son los problemas que quisiera yo terminar mencionando? Primero, que vemos que este asunto de la transmisión en edades más jóvenes, ejemplos como el de los estados de Florida, de Arizona, de Texas o en California, la edad promedio de las admisiones y de las muertes ha ido disminuyendo. ¿Esto es porque se hacen más pruebas a los jóvenes? No sé. No está clara la explicación. Es por la diferencia en las conductas de los jóvenes y de los viejos. Los viejos nos resguardamos más que los jóvenes. No se ha hecho esta medición de la movilidad por edad, pero podríamos empezar a meter algo en las encuestas, y esta es una recomendación para el observatorio, si podemos empezar a hacer un drill down en términos de edades en la movilidad. El asunto de la epidemia que en los viajes y que queda esta epidemia, lo que sucede en Nueva York, se ha demostrado que la transmisión ha bajado mucho la R, y ellos han abierto ya sus viajes, no han abierto las escuelas, pero ya los aeropuertos están funcionando. La cuestión fundamental sobre el momento en que la epidemia comenzará a resurgir está en función de algunas cosas como, no me gusta decir regreso al trabajo, porque no hemos parado de trabajar, estamos en la casa, pero no hemos parado de trabajar. Es insultante que digan regreso al trabajo. Regreso a la escuela sí, porque, pero también no van a decir regresar a estudiar. El asunto de la estacionalidad que yo les mencionaba, los viajes, y el asunto de la reemergencia, que no está claramente si eso se está aprendiendo mucho en este proceso. ¿Cómo están actuando los gobiernos? No la podemos capturar fácilmente en nuestro modelo. La respuesta de los gobiernos creo que es un problema que tenemos que trabajar más seriamente. Hemos asumido algunos riesgos en términos del regreso económico, pero estamos tomando variaciones en niveles altos. Tenemos que mejorar nuestros modelos con lo que es la respuesta política y las proyecciones, y estamos analizando estos posibles cierres de la economía en diferentes dimensiones, por edad, por espacio, por tiempo. Pareciera ser que algo que no hemos todavía aclarado es justamente lo que sigue, ¿no? Para nosotros. Lo que sigue es que tenemos que añadir más conductas individuales. Hay una gran negación de mucha gente, hay mucho rechazo a la epidemia. Esta situación de que está fatigado, que estamos fatigados, que ya queremos que las cosas cambien, no la estamos todavía incorporando a nuestro modelo, y lo tenemos que hacer. Estamos incorporando superficialmente las respuestas del gobierno. Necesitamos escenarios más realistas. No es suficiente con decir cierre total de la economía, eso ya prácticamente nadie lo acepta. Y otro mensaje también para el observatorio: tenemos que incrementar la granularidad de lo que es la apertura. Es decir, cuando se cerró la economía, se cerró prácticamente de golpe los grandes grupos, pero abrirla es qué está pasando en los bares, qué está pasando en los restaurantes, qué está pasando en las escuelas. Y yo creo que no tenemos esa granularidad, y podríamos en un momento dado mejorar mucho nuestras estimaciones en términos de las proyecciones. Me parece que nuestro principal problema, y ahí sí necesitamos mucha discusión entre nosotros, es para mejorar la comunicación de los resultados. Cualquier feedback de su parte es bienvenido, y sí necesitamos su ayuda para cómo seguir elaborando estos escenarios más realistas que yo les mencionaba, que es un pendiente por realizar. Yo no puedo evitar agradecer a mucha gente, particularmente a los gobiernos, a la Organización Panamericana de la Salud, justamente a la Universidad de Miami, al observatorio que dirige Felicia Knaul, donde está Michael y Héctor. Y les recomiendo mucho que se vayan a esa página porque se van a entretener por un buen rato. Muchísimas gracias.
De nada. Thank you, and thank you, Dr. Knaul, for a wonderful set of presentations. We're going to start question and answer and discussion section right now. Please do submit questions if you have them in the Q&A function at the bottom of your Zoom screen. We'll get to as many as we can. And we will also have an upcoming webinar with Dr. Patricia Garcia, which I mentioned at the beginning, which will incorporate more discussion of what's happening in Peru and also the broader view of the entire region. So the first question I have is for Dr. Lozano, which is on the use of masks. IHME is modeling the impact of mask requirements, but we don't know a lot about whether people are using them properly. Can you speak a little bit more about the efficacy of using masks and how you're trying to incorporate that into your models, as well as the proper material or other research for what kinds of masks are out there? I understand you have some research on this.
Michael, may I go?
Yes, of course. This is for you.
In English, is okay?
It's okay.
Okay, so we are working with a very important group. When I say we, is mostly me, working with a group in Mexico from the Polytechnico. Then they are engineers and are doing a lot of tests about the fabric. What is the best fabric for the mask? And in fact, they are creating a norm for producers and a norm from users. Besides that, there is another group that is trying to promote the best use of the masks, because they did a survey and they found, and of course 90% says I'm going out my home using mask. But when it started the question about how is the proper use of the mask, the number decreased to 45%. And when you ask others, how do you see others using the mask in closed settings, and decreased to 20%. So the efficacy moves down very fast. And we are not taking that in consideration. Our model is just taking the positive response. Thank you.
And I have one more specific question for you before we open to the panel discussion with Rifat and Patricia Garcia. And that is, has IHME been modeling the impact of seasonal influenza on COVID-19?
Thank you. We started doing that, but we switched to pneumonia. The reason of pneumonia is more sensitive to the forecasting. It is, we are not using influenza or pneumonia as an explanatory variable. We are using that to help us in the prediction of the projection. So that is the use of pneumonia. However, since we are starting the season of influenza, we need to be aware about the not the incidence, more the access to the vaccine. I don't know how it's going to work, the vaccine to influenza, and never is enough. But in this moment, we don't know. And maybe Patty can tell us about what is the plan in Peru, but I haven't listened more in other countries. Over.
Okay, thank you. First, let's have a response to the presentations from Rifat, and then Patty, and then after that, we'll have some more questions from the audience.
Thank you, Michael, and huge thanks to Felicia and Rafa for really excellent presentations. I've really enjoyed both and learned an awful lot. And sort of three things that really strike me in the presentations. The first is the inter-country variation in Latin America. So there's huge heterogeneity in both the responses to the pandemic, but also the outcomes in terms of number of cases and in terms of number of deaths. The second observation is the critical importance, as you've very briefly laid out, of getting sub-national level data. Averages are quite misleading. We see huge variations among states and municipalities in the The Brazil and Mexico examples are very revealing. So having a one-size-fits-all national policy is just not going to cut it. So one really needs to understand what is happening and the dynamics of the transmission and the epidemic at subnational level. And the third, what Rafa mentioned as being a sort of smart lockdowns. So I would say smart policies or targeted policies. In moving forward, it is critical to use subnational data and the dynamics at subnational level to develop highly targeted interventions and develop scenarios. Rafa showed us 3 scenarios against the base case at national level, but that needs to be generated at subnational level among a number of policy options, and think through what is an optimal mix of policies, not just one scenario. I think the IHME has the horsepower to do this in terms of computing, also in terms of data. I think because for policymakers, it's not just telling people to wear masks, but it's also mobility, opening schools maybe with different time of access to school, again, back to work policies, especially for those in Latin American context, huge proportion of the population work in informal sector. They really don't have the luxury as many countries in Europe have had to furlough people, or the government hasn't the luxury, or the corporations or institutions to furlough people. So these people need to be able to get to work and earn an income. So this is a huge challenge. So the smart policies in relation to back to work, getting people back to work while ensuring protection, because those are the individuals who are at the greatest risk. As we're seeing, those in lower income groups are ones with higher income levels, comparing IMSS, for example, in Mexico with the private sector. So the smart policies need to be very granular. And the policymakers need to review these on a weekly basis. If one is going to have 3 weeks on and 6 weeks off in terms of the responses, we have to be very careful in the policies that are introduced and the policy mix. But I think the kind of research that is being undertaken at the University of Miami and IHME are critically important to shape the responses going forward.
Thank you very much. Now, some comments from Dr. Patty Garcia, please. Look forward to those.
Thank you so much. First of all, thank you to Felicia and also to Julio for the invitation to participate in this webinar. And also because, I mean, it's so nice, even at a distance, to see so many friends and discuss the issues that, I mean, we are living on and we are concerned about. So it has been great to listen to what Felicia is doing with this observatory. And also it's always nice to hear what Rafael does with all the data and with the people with IHME. I would like to do at least, I have 4 comments that I would like to make. So one of the, and maybe I will repeat a little bit what Rifat has said, okay? So in Latin America, we are living different epidemics, and within our own countries, we are living also several epidemics, okay? So I completely agree with the fact that it's not enough to have just the data from Latin America or the data in each country, but we need to know what is happening inside our own countries, especially because what has happened is that the epidemic was introduced in all of the countries in the bigger cities, and later on it has been moving along. And so that means that we have different timing, but also one of the things which has to do with contextual issues in Latin America is that in most of our countries, I have to talk about Peru, but several others have the same problem, is we may have these mega cities, huge cities that have everything, but then you move outside and then you have health systems that are even weaker, less capacities to manage cases, more problems for communication, etc. So the consequences of the epidemics are going to be different. Not only the implementation or the speed of the implementation of the policies, but also the consequences are going to be different, okay? So the first thing is highlighting the issues on Latin America, and the contextual issues are critical, okay? And I think it's a wonderful work collecting information on policies and making that extra effort to understand what happens at the subnational level, okay, number one. The second thing is, I think we need to make an extra effort, Felicia, to try to also bring the contextual issues that happen in Latin America. And maybe this is also for you, Rafael. You know, one of the, if you look at some of the, and this is something that I will be probably talking about Peru, when you were showing the curve that you got from Google to see if people are staying at home or not, you could see that it looks like in Peru, most of the people are following the rules, okay, and are staying. I think we have the highest curve of not moving with your cell phones, okay? But that's not taking into consideration that several people don't have the phones, okay? Although we have almost one phone per person in Peru, but several people had several phones, okay? But the other thing that is happening is that, which is completely different from Europe probably, is that the number of people living in one house might be much higher. So overcrowding and infection within the houses has been a big issue. We even have this practice of extended families in which vertically or horizontally, more likely vertically, families are living together with each other and are completely connected. So you may have 18, 30 people, all supposedly in quarantine, but several of them are coming out and all of them are having contacts with him. So I wonder if there could be some type of correction by density, population density, crowding or overcrowding in housing, which I think has been and is one of the problems that we're having, okay? So policies are important. We need to understand the contextual factors, okay? And within those contextual factors, I think, Felicia, you have talked about political issues, and several of our countries have been going through political issues that have made even more difficult to implement policies. And then social, cultural issues that both of you, well, Rafael has mentioned, I mean, how to include in all these analyses, I mean, what people are doing, because they may be saying that they're using masks, but they may not be doing it. Or what we are seeing exactly as Rafael was saying is that people, when they go outside, they're using a mask, but once they are at work, they are not using it, okay? Or in closed spaces, they are not using it, and that becomes a big issue. So then contextualization is an issue. And I think in some way we need to see how can we include that. The adoption of policies is not only the government releasing the policies, having the policies at subnational level, what are the other factors that don't allow those policies to work, and the adoption of policies. My other two comments are very specific, okay? One that I would like to make about one thing that you presented, Felicia, about Chile. I think the stories may have two faces also, because what you're saying is like Chile is a model to follow, but I'm not sure about. I mean, I have heard talking with other epidemiologists from Chile, different things. And actually Chile started very well, but there were several academics that were complaining that the data on mortality, for example, or infections was not really reliable. And there were things that were not really open. And then they have several changes on definitions, okay? And the other thing is that after a protest, they had a second wave that was quite important. But you know what? One advantage that Chile had, and this is contextual also compared with other countries, was a much better health system. But also some people complained that the way they managed some of these policies that were directed to the people that were having more resources and the people that had less resources was not included was a problem. So I think when we do the analysis, we need to try to take into account all the other ways of seeing it. Costa Rica is a very good example. I will say a much better example than Chile. I mean, Chile is much closer to us and we have discussed this situation several times. And my last comment has to do with influenza. Rafael pushed me to say something about influenza. We were concerned because compared with you in the Northern Hemisphere, we have gotten together coronavirus and the time of the year in which influenza usually hits us. And actually, unfortunately, although the government, right in April, they had all the vaccines because there was an anti-vaccine group that started sending messages that if people was going to get vaccinated with influenza or the nurses were going to come to the houses, they were going to bring coronavirus. So the government got scared about those messages and decided to stop the vaccination, and the vaccination never happened, okay? So actually I was one that was, I mean, really upset and screaming why they stopped the vaccination. Everything was prepared to go door by door, vaccinating people together with the municipalities, and that was stopped. So we decided to try to follow what was going on. And actually I have to tell you, it's quite interesting. We have about 8,000 or more than 8,000 people who had been screened for influenza. And by this time of the year, which we are supposed to have like the highest peak, we have zero positivity, okay? And this is people with symptoms that were going to be seen by primary care or at the hospitals. And then as part of the randomized trial that we have for a treatment for COVID, we have about 700 people tested for both coronavirus and influenza, and there we have one positive case, okay? So could it be that the fact that people are using masks, that especially that the youngest are staying at home, because we had a very strict policy until probably 4 weeks ago, and it has until 4 weeks ago, but now it's again back that kids cannot go out for more than half an hour a day, okay, and they have to go with masks, and nobody's at school. Could that be the reason why there is almost no influenza and we have not seen infections? And I have to tell you another thing that I was looking at some data about other respiratory infections. Our data on pneumonia is not that good, but I started to look at the data on tuberculosis. And you know that by this time of the year, compared with other years, we have about 71,000 less new infections for tuberculosis. Although we have decreased the screening by 25%, I have to tell you, too, okay? But still, so maybe masks were doing something, not enough to control coronavirus, but enough for these other infections. And that's it.
Thank you for your comments. Those were excellent points from everybody. I'd like to invite members of the press, if you are watching, to identify yourself in the question and answer session. We'll do our best to answer every question we have time for, but we also only have about 10 or 15 minutes total left. I do have a question though for all of the panelists surrounding vaccines, which have been in the news lately in the United States and certainly in Europe. If we assume that there is an effective, safe vaccine developed maybe by the end of the year, if we're optimistic about this, what are some of the challenges to implementation and rollout in the Americas? How long do you think it would take to deliver vaccines to broad population? And what are some of the basic impediments that you foresee? And any one of you can take this. It wasn't specified as to who.
Yeah. Well, I can comment, and I'm sure everyone will want to comment on this critically important issue. I mean, there are a number of challenges. Some relate to some are technical issues, some are political issues, and some are sort of sociocultural issues. So in relation to technical, one has to develop production capacity and scale this up very rapidly. we're talking about hundreds of millions of doses that need to be produced in a very short space of time. So that's one challenge. The second challenge is actually being able to very rapidly roll out a vaccination program. Producing a vaccine does not mean vaccination. One has to have supply chains, one has to have functioning health systems. I think Patty's example in Peru is very revealing. That's quite worrying. So one has to prime the system so that when the vaccines are available, the systems are able to scale up rapidly and effectively to get numbers up and to reach herd immunity, which is critically important. The third technical issue is being able to reach individuals. So one has to be able to very carefully plan how to roll out the vaccination program. Is this going to be through vaccine days? Is it going to be door-to-door vaccination? I mean, these require very careful considerations given the different sizes and shapes of the countries we have in Latin America. The second issue is politics. Now, politics of, on the producer side, the countries that are producing these vaccines, making these vaccines available. We've heard of vaccine nationalism. Will these vaccines be available equitably? If so, who's going to pay for them? So I think that's a very big political question with a big P, not just a country level, but I think it's a global challenge that that needs to be tackled. And we're already seeing a number of rich countries not contributing to WHO efforts regarding sort of common research and production of vaccines. The third issue is sociocultural, and I'm sure Patty will want to say more about this. Again, so the anti-vax movement could lead to a sort of huge barrier. And there are already people raising concerns about rapid approval of vaccines. So we need to make sure that the vaccines are safe and efficacious, because if there are issues with the introduction of vaccines, that's going to give a lot of armamentarium to anti-vaccine movements and could really hamper our efforts to contain this coronavirus pandemic.
Thank you. Patty, would you like to add in?
Okay, here. Well, I completely agree with what Rifat said. I think there is a lot of expectations about the vaccine itself, that there are very many things that need to happen. One of the things that is happening regarding the access is that several Latin American countries have gotten together with PAHO and are going to participate on this platform called COVAX to assure that at least we will have the first lot of vaccines, at least 1% of the population that will access the vaccines as soon as they are available. Most of these countries, Peru is included, supposedly will be getting about 20% of the vaccines that are needed, that will help the vulnerable populations mainly, and probably health providers. So that is already ongoing, and I think it's a very positive thing. So one is that we have these vaccine trials, phase 3 vaccine trials happening in several of the Latin American countries. Brazil is already working, Argentina, there is in Chile, in Peru, we just started. So that is one thing that is positive. The second is the participation in COVAX. But the third one, I completely agree, the kind of things that still need to happen are how to assure the operational issues that need to go together with the implementation of a vaccination in this setting, okay? And the second, completely agree, is I mean, in our cases, I think the political thing is helping to push the governments to do it, okay? But the fear is if some anti-vaccine groups will start, and I think they are already starting to start releasing some of the myths and issues that can go against the vaccine. Here we had a survey that showed that about that probably it was like, I think it was like 75% of the people are convinced, interested, and would like to be vaccinated, okay? But there was about 20 to 25% that thought or that think that with the vaccine, they will be introduced with a chip to control themselves, okay? So can you believe that? I mean, it's already that those kind of things are happening. So on the other hand, I have to say that on Sunday, this website here in Peru to get volunteers for the first clinical trial was open at 11 a.m. and it had to be closed at 11:10, okay? Because we already had about 4,000 volunteers, okay? So we'll see. I hope that things move along well with the vaccine, that we really, that especially the big countries, okay, which are the ones that are fighting actually, do things in the right way, which means wait until there are results before they started approving the vaccines, which means that we know very well that the vaccines are effective and are safe. And, and I hope that our governments do the right thing, planning well the operations that are needed in order to vaccinate.
Yes, thank you. I hope our government does that well too. I fear they won't. We have several questions from the Mexican press, including one from Natalia Vitela for Dr. Knaul about positivity in Mexico being, or rates of positivity for tests being over 60%, and the World Health Organization recommending opening when it's 10% or less for positivity. And Natalia asks about what the risk of reopening might be now in Mexico. And this can be for Rafael Lozano as well as there's a slide about deaths based on different health institutions in Mexico that we could revisit.
Mike, thank you. Natalia, muchas gracias por acompañarnos. I'll answer in English as long as the Spanish translation is working well, and I will turn some of this over to Rafa as the expert. I mean, I think there's no question that without adequate testing, opening is a rash thing to do. But opening would be the right thing to do if there were adequate testing and mask use. There are actually a series of questions here about why certain leaders, particularly President of Mexico in this case, is not always using a mask in public. All I can say is that using a mask is not an invasive procedure that causes danger to anyone. It protects others, and it's a good message. We need our leaders to share good messages with the population, messages that are not costly and can only do good. And so that's a very easy intervention to recommend that will certainly help with an opening that many are saying is required in countries with high rates of informality, with risks of increased poverty rates. Hunger is also a huge risk for people's health. And so we want to open safely and get people back to work. And that positivity rate, which means testing both symptomatic and asymptomatic in order to try to identify and track outbreaks and do appropriate testing, is absolutely key. I'll turn over to Rafa for the risk. And if we have a minute, Mariano has been translating, and that's his data. So Mariano may want to jump in. He's a panelist as well in panelist privileges, or send us a note that I can share either way on his very unusual data on the institutional differences. Rafa, please.
Thank you, Felicia, and thank you, Natalia, for the question. It's hard to have a standard for the whole world with it's a big inequality about testing. It's hard to have a standard when countries like US concentrate maybe 30% of the all tests of the world, and other countries don't do the same. So it's easy to put the standards, but the question is, what are the basis of that? So in the other side, I cannot say that the Mexican data are useful for policy, because it's a very selected population. So of course, the people need some guidance and to make risk the moment that they have to go out. And they don't have that. So the positivity index at certain limit is good, but in the case of Mexico is useless, honestly. And If we want to go in the direction, the political direction, go ahead. In the technical side, it's useless. The other point is I want to make just a comment, because I heard from Rifat and Patty too much about Latin America. And you know, it's important to put the Americas as a whole, not only Latin America. I'm very sorry, Patty, but what is happening in the US is amazing. This is the first time that we have to introduce and compare how is this thing, and maybe the best health system in the continent, Canada, is having a lot of problems due to the people. So let me just put two more countries in the good examples. We never speak about Cuba. Cuba is a very good example that we need to consider, better than Costa Rica, and we need to incorporate also Uruguay as another good example. Over.
Americas.
You know, if we could just actually go back just 1 second on the vaccines, now that we're actually being a little bit more polemic, I think. The news out of the Washington Post and others yesterday is that it's the US government that isn't going to collaborate on COVAX, that is going to pull out, and isn't going to support WHO. So if we say it like it is, in the middle of a pandemic is not the moment to decide you're going to sink the ship. It's the moment to try to help lift the ship up so it does well in the waters that are both murky and very rough. And I think we have to say it like it is, that's a huge problem for bringing a solution to our world. PAHO is trying to make use of very important experience that they have with vaccines and purchasing platforms that Rifat and I have worked on quite extensively and looked at. And that should be able to give a lot of important knowledge to support access to a vaccine when it's ready. But impoverishing the institution that could help make that happen isn't going to do us any good. And I had wanted to jump in on that earlier. Mike, back to you and more questions.
Okay, thank you. This is for Rafa, and projections for Mexico in general are on the top of people's agendas for quite a few audience members. I think we had almost half of our registrants from Mexico for this webinar. So what is yours and IHME's forecast for Mexico for the next few months? What do you see happening between now and maybe October, November?
I have good news for some states and not good news for others. In average, is increasing, and our forecasting is 118,000 deaths due to COVID at the end of the year. You saw that is a leading cause. What is happening in Tabasco is very interesting because it's decreasing. What is happening in Mexico City maybe also is good, but is going to go up in November. So unfortunately in Mexico, we need to consider a lot the impact of the seasonality of infectious diseases, respiratory infectious diseases, and is going to affect. And in the second end, I take the point of Rifat. Our economies are totally different to other areas of the world. We are working, we don't receive the check every week. So people have to go out to work. And that is as Rifat was saying, we need to incorporate more public health recommendations. We need to educate a lot of the population, and we need to facilitate the way to transit in the street, in the public transport, and in the work. This is not easy, but it is necessary to consider, and we need to reject all these rejections against the pandemic. The pandemic is, we cannot deny, it's real, and it's killing a lot of people. In Mexico currently, we have 65,000 people dead, reported, I want to see. So we cannot reject this. So I totally agree with Rifat. It's totally different, the strategy for our continent. And I agree that Latin America is not as other countries, but in the US, the more complicated area are related with Afro-Americans and Hispano-Americans. That's the people that are paying the worst part of the pandemic. Over.
Thank you. We have another broad question I think we can take. Well, we're still a little bit over time, but we're within the margin of error here, I think, at this point, which is, as long as we're bringing the United States into this conversation, we would be remiss to avoid the populist question surrounding leadership in the Americas, both in the United States, in Mexico, as well as Brazil and elsewhere, and the political components of the pandemic. So this question is broad, first for Dr. Knaul, what we see as the chief political impediments to evidence-based policy in the Americas, and what the effects of populist leadership have been during this time frame.
I should turn that back to you as the expert in Brazil, which actually it cleaves along party lines. But I'll say what I know are your incredibly important results. I don't think we're seeing in any country that same kind of political cleavage that we're seeing in Brazil. Interestingly enough, it may be actually pro-poor in some ways, because it's the poor states, as you've taught us, that are actually implementing stronger containment policies and public health policies. But overall, I think what we're seeing throughout the world, we have two countries clearly in Latin America, Mexico, and Brazil. We have several others around the world. We have, many would argue, one being the United States in North America as well, where this pandemic is being used to share messages that are not evidence-based. And I think that's really the key. There is difficulty in understanding this disease. The science is a science that is in constant evolution, but there are some messages that are very clear and that need to be shared clearly. And I think one of the key messages that we know in public policy around public health is that you need messages that are consistent, that are simple, that are straightforward, and that are easy for people to follow and understand and change, not over short periods of time, but rather continue, so that you can really educate a population. What we're seeing, unfortunately, in these more populous countries is it's basically what we've been calling punt politics, where it's up to the states at the subnational level to try and figure it out. So you can have 27 different policies in Brazil and 32 different policies in Mexico. And that isn't going to help to have a clear set of public health messages that people can follow around something like mask use.
Thank you. Rafa, one more quick point, and we're over time, and then we'll go to closing remarks from Dr.
Thank you very much. The best person to speak in this is Rifat. It's his area, this one. But what I want to say is that sometimes evidence is not exactly the best solution, because we are building evidence in time. So we cannot make judgment about what is happening, what happened before with the evidence that we get now. And sometimes that's the mistake that we are doing. In other side, politicians are taking advantage, and there is no evidence to express that like our evidence. So if we don't have evidence, the evidence is continue doing the same thing. And they don't open to explore new avenues that are necessary to open. So I hope I'm trying to just put in the two angles. One angle is don't make strong judgment about evidence that we are knowing now. And second, please don't use no evidence as an evidence to stop things that can be happening. Over.
Thank you. I'm afraid we're running short of time here, but I will turn this back over to Dr. Knaul for closing remarks. I'd like to personally thank all of you for your comments and give a little bit of a preview of an upcoming webinar with Dr. Patricia Garcia featuring evidence from Peru, as well as Clive Landis, the Vice Chancellor of the University of the West Indies and Director of their COVID-19 task force. So we'll have more of these as we have more information and more material. And I look forward to continuing the conversation with all of you. Thank you. Over to Dr. Knaul.
I think there are actually several more questions and some addition from the press. I would say that one piece of key information that you're hearing from all of us is that pandemics should not be politicized. This is about human lives. This is about people losing their lives and about many who recover but see long COVID, months and months of very debilitating illness where we don't actually know what the long-term effects are. It is inappropriate to politicize an issue of public health when we're seeing this kind of externalities associated with it. That's sort of the definition of what I would say is a pandemic. In summary, I think we've also heard, and I'm very grateful to our panelists, to Dr. Rifat Atun and Dr. Patricia Garcia, because the comments were incredibly helpful. But one thing I took away is that we do have to try to be granular, that we need to go to not only the state, but even the departmental and the municipality level to try to get some information and use the richness of that variance to understand better how public policies can in the future be better managed, better thought through in order to control future effects of this pandemic and be more pandemic ready for the next time. And also what Dr. Garcia has been constantly saying to us, which is there are other explanations, there are other reasons why people are not behaving in ways that might be best for their health. And sometimes they're actually behaving in ways that are best for their economic health, which in the longer run may be best for their health. So these are very complicated pictures that have to do with culture and know-how. And I might end with just one thing that I was taught over and over again. It was beaten into my head when I was a student, when I went to work and live in Colombia. Anytime I was working in another country, it was to realize and to be told that the messages that people were giving me, the population was giving me, the people I was interviewing were giving me, might have a lot more evidence in it than what I thought I had been reading in a book. And so I could have summarized, I think one of the things that Patricia was saying is that we need to ask ourselves why people are behaving the way they are, and therefore think of ways to be able to support them, to be able to protect themselves, to protect themselves better. Just to thank then Dr. Lozano, we have been drawing out of his data constantly. It's an incredibly rich source of information. And basically, Dr. Lozano is a global public good in what he's doing for the world, in managing all of these data and sharing it globally. We know that it's about the Institute for Health Metrics and Evaluation, but we also know that you are at least the Latin American heart of the Institute for Health Metrics and Evaluation. And it was one of, I think, Latin America, definitely at the subnational level. The reason that we had data so early on was because of the work that Dr. Lozano was doing to make that possible. And that's a huge gift to our region, something that we have to treat as such and continue to work with those data and collaborate with him and others. And of course, to thank all of our colleagues. We had several of our researchers and students who were doing the translation. We did that deliberately because we feel that they know the topic, and we hope that that was useful. They were very helpful to me in doing this. Thank you very much for taking that backseat and difficult job, Dalia, Fernanda, and Mariano. And to thank my co-director, Mike Touchton, for moderating this, and of course, President Frenk for supporting this initiative and for constantly helping us to understand better what's happening in our region and to be able to help use the evidence that we're sharing right here at home at the University of Miami and in Miami and South Florida. So thank you very much. We will be back in the next couple of weeks, and the grabación, the video recording of this will be available at our University of Institute for America's website for you to consult. Please send us comments and suggestions either through the Observatory website or directly at the Institute for Advanced Study of the Americas. Mike, anything else?
Yes, just one more note to everybody who had questions that we could not get to today, including members of the press, members of the public as well. Please do get in touch with us. With lots of opportunities at the Institute for Advanced Study of the Americas. We pledge to answer all of your questions and sit for interviews to talk more about our work as soon as we're in contact to do so. So we'd love to get to the 40 plus questions that you all asked, but we regrettably don't have the full afternoon to do it this time. But thank you all for your attendance and participation, and I look forward to seeing you again soon.
Thank you.